After reading her book, it's clear to me that my guest today, Leah Hazard, and I are cut from the same cloth. Writers and midwives on a mission to help women have a deeper understanding of the beauty and power of our bodies, our uniqueness, greater ownership of our perinatal and gynecologic experiences, while illuminating the significant non evidence based practices that still persist in the Western obstetric and gynecologic models that often lead to unnecessary interventions and at times even harms for women, mothers, and babies. A Harvard University grad with a degree in English and American literature and a master's degree in directing from the Royal Scottish Academy of Music and Drama, originally planning to work in theater, film, and television, the birth of Leah's first daughter in 2003 prompted a change of direction. She retrained and worked as a doula, providing practical and emotional perinatal support to families across Scotland for 6 years before making the biggest leap of all, embarking on a career in midwifery. Leah's memoir, Hard Pushed, A Midwife's Story, was a Sunday Times bestseller in the UK. She hosts the popular podcast, What the Midwife Said, and is a frequent commentator on women's health across the media. Today, I'm really excited that we'll be exploring the body's most miraculous and controversial organ, the topic of her latest beautiful book, Womb, The Inside Story of Where We All Began. Our conversation will cover the gamut of periods to fertility to pregnancy and into menopause. If you have or had a womb and want to know more about your body and the body politics of this powerful organ and its role in our lifelong health, we welcome you to join us in this wonderful conversation that I know we're about to have. Leah, welcome, and thank you so much for joining me.
Thank you. It's a pleasure, and thanks for that great introduction.
So before we get into the fascinating story of the womb in your new book, tell me about how you made the pivot from working in journalism to becoming a midwife. Not everybody who has a baby makes a giant career leap like that, and you had a lot of training behind you before you took that leap into a whole lot of new training.
Yeah, it's true. Not everybody who has a baby decides to become a midwife, but it has to be said that a lot of midwives actually come to the field later on in life because they've had babies and because their priorities have changed, or they're now fascinated or intrigued or challenged by birth work. So you're absolutely right. I was working in journalism. I was actually working behind the scenes for BBC Scotland in 2003 when my first daughter was born. And I thought I'd been very well prepared. I went to all the classes, read all the books in pregnancy, and then the birth experience was just nothing like what I had expected. Very difficult, as many births are, but just took really unexpected turns. The care I received was not what I anticipated. I had been confident in my body, but for some reason that confidence didn't come to fruition. And then after she was born, fortunately healthy, I still had problems with feeding and really just was really perplexed and disappointed with why I'd had this experience. And the more I spoke to other women, my friends who were having babies around the same time, I realized that almost all of us actually had been disappointed, surprised, shocked, let down in some way by the experience or by the system that we'd been through. And I'd always been interested in women's health, even though my career at that time wasn't in that field. And I think the birth experience just triggered that interest in a new way. And I had a bee in my bonnet. I became pretty obsessed with why this experience had been traumatizing, and is a strong word, but just not what I had expected and so difficult for me and for my friends. And I started to wonder whether there was any way of making the experience better for other women. Now, obviously at that time I had a baby and I wasn't really ready to go back to school because I had just been through a lot of education. But it was then that I found out about the role of the doula. And I thought, this is a role that I can really incorporate into my family life and that can do in a kind of independent way, but also brings me into the birth space. So I did that for 6 years, had another child, and ultimately decided the time was right and really wanted to be the one to make that leap, to be the person to provide all of the care, not just the emotional support, but to be that kind of autonomous clinical practitioner as well. So I retrained as a midwife, which in the UK is a 4-year, 3 to 4 year degree, depending on where you go, and qualified in 2013.
That's amazing. Leah, you talk about something that is so near and dear to my heart. In fact, while I am not a trained journalist, I just finished a 6-month journalism program through Harvard called Media and Medicine. And the entire focus of my 6-month project has culminated in an article on birth trauma specifically and why women are experiencing such deep, profound disappointment in their birth experiences, finding out it's not what they had anticipated, that all their best loved plans are usurped or distracted, particularly in the hospital environment. And while you say for yourself, trauma may be a strong word, I want to just say 2 things about that. Obviously, I can't know the extent and depth of your experience, but a significant portion of women now in the UK and the US are actually able to be diagnosed as having PTSD, actual diagnosable trauma as the result of their births. And many women almost self-gaslight and say, okay, I have a healthy baby and I'm healthy, so maybe it wasn't trauma. Can we go in that direction a little bit? It's such a pressing issue here and in the UK and in so many places that women are struggling with now, and what we can do to help women through this conversation.
Yeah, it's a fascinating and really timely question. It's a big interest of mine, and actually just this year completed training in birth trauma resolution therapy, which is an intervention that midwives and other professionals can use to help people move past perinatal trauma. And you're absolutely right. Women and people who birth do tend to second guess themselves and say, my baby is healthy, or I was told to get over myself because my baby's healthy. And other women have it worse. And at least I'm not in a war zone, or at least I'm not a refugee, or there's always going to be somebody worse off. And we minimize our own pain. But absolutely, birth trauma is occurring on a mass industrialized scale at the moment. And a lot of that is to do with the mass industrialized nature of the maternity system, which has its differences between the US and the UK, but also some major similarities. And because the system has become such a kind of monolithic, industrialized machine, it's not able always to give the individualized, person-centered care that everybody deserves. We're very medicalized, we're very interventionist, very defensive practice in America, and also to a certain extent in the UK. Litigation is a big issue in obstetrics and midwifery. So people aren't always having that individual kind of holistic experience that they deserve. And this clearly has massive psychological consequences for a lifetime, really, especially if it's not properly addressed and given the time and space it needs.
Yeah, I'm creating an online program, which is an extension of something that I had created in COVID, the Mama Pathway. And we have a big segment on birth trauma prevention, but also birth trauma resolution. I think even just acknowledging it as we are here, someone might be listening going, oh, I have actually been telling myself that what I experienced wasn't as bad as it was, or it didn't happen.
Mhm.
So thank you for bringing up your own story. I'm curious as to something about your practice. So when I was a midwife, then I went to medical school. When you finish medical school, you pick a residency, the field you want to specialize in. And at that time, I thought, okay, I'm going to go into OB-GYN and I'm going to just change the world, basically. And I remember a gentleman named Marsden Wagner, and I
Mhm.
had a conversation. He was head of neonatal for WHO. He was a huge advocate for midwifery.
Mhm.
And he said to me, I will be in your sidecar of your motorcycle as you go through. He was in his 80s at the time. As you go through your training, but I just want you to be prepared for the potential of it being a dark night of the soul. And
Mm.
as I was going through my obstetrics rotations, I realized that, and then also as I was interviewing at programs where I was being told things like, oh, at our program, don't worry, we don't have midwives, so you'll get to do all the births. Or
Mm.
our C-section rate is 38%, so you're going to get plenty of surgeries. And then litigation risk and all the things they don't do. And I thought, I am going to spend my life either becoming something I never would want to be as a practitioner or being very alone and very unhappy. And I actually switched to family medicine with obstetrics because it's a much more holistic approach, even though it's still steeped in the medical model. But I also know so many midwives, at least here in the US, who go into midwifery wanting to be there in certain ways and offer certain kinds of opportunities for birth, particularly in hospital when they're working in hospital, because it's a little easier to get the birth you want in a birthing center or home birth. And the midwives themselves find themselves up against tremendous limitations and obstacles in the system. So many of the midwives themselves have come to feel traumatized, frustrated, depressed. And I'm wondering how the UK is a much more progressive birth system than ours, but how has that been for you? Have you been able to be and who you want and do what you want as a midwife, or have you come across some of these limits, or both, some of both?
Yeah, funnily enough, I wrote another book about that too. That was my previous book, Hard Pushed, a midwife story that came out in 2019. And it's not published by an American publisher, but I do believe you can order it from the States, or you can even get it on ebook and audiobook. And so
I
that
will be
book
doing that today.
Great. Yeah, sorry, not to plug the book,
Oh,
just
no, it's
because
great.
it's
We
really
should
fair
plug.
question. Yeah, no, it's very much, that's really what that book was about. I wrote that after I had been working as a midwife for about 5-6 years. And at first, when you qualify in any new career, you're just trying to survive, right? You set the bar pretty low for yourself. You want to survive and you want to not hurt anybody else either. And then after a few years, you really start to look around and get more of a sense of systemic pressures, and you get given a bit more responsibility. People expect a bit more of you, and that has its own pressure as well. And what I experienced, and I think what many midwives experience around the world now, is this real sense of moral injury of wanting to provide a certain standard of care. And I was trained in an excellent system to provide a really world-class gold standard of care. You go into the service wanting to provide that, but then unfortunately things like lack of resources, lack of staffing, institutionalized guidelines, protocols, and so on prevent you from giving that kind of care. So day after day, you're turning up to work, wanting to give women and people the absolute best experience, wanting to give individualized care, wanting to facilitate their choices and what's right for them, and not being able to do that either because of institutional expectations or just practical limitations. And I wrote a lot in the book, and I've written a lot since about how that felt and how that feels. And it's still something that I have to reckon with every time I turn up to work, to be honest. I really don't take my future in midwifery for granted. I take it one shift at a time because things are so challenging. And it's hard. Yeah, it's really hard. And I think especially through the pandemic, healthcare providers of all stripes have had to really reckon with this issue of wanting to do the best, but really being hamstrung by circumstances around you. So it is really hard.
Yeah, it's really hard doing obstetrics as a midwife in the hospital as well, and always doing my best, and then always coming up against risk management and what they wanted me to do, even if the evidence wasn't there. And that's something I want to dive deeper into as we get into the podcast. To this book, one of the things that you emphasize in this book is how little so many people know about their own bodies. And we know that surveys show that many young women, a lot of young men, can't accurately identify the parts of the female reproductive system. I am regularly explaining the difference, for example, between the vulva and the vagina. And I wonder, from your perspective as a practitioner and a woman, why you think it's important that women have a better understanding of our uterus and our bodies in general.
It's definitely important on a number of levels. I think for all of us, it's important for us to understand the reproductive system because every single one of us has an opinion about what should or should not happen within that system. Especially, there are very strong opinions about what should or should not happen within the uterus, right? You ask almost anybody, any country around the world, male, female, or in between, what do you think about abortion? What do you think about pregnancy? How do you think contraception should be handled? What about sex, fertility, And everyone will have some kind of opinion. But if you drill a little bit deeper and say, yeah, but do you actually know even what the uterus is or looks like, or how it functions, or how conception happens, or what pregnancy gestation looks like and what can go wrong? Very quickly you come up against some kind of brick walls because people just don't actually know the simple physiology of reproductive function. And I have this old-fashioned idea, if you're going to have an opinion about something, you should know how it works. And the reason that's important is because we live our lives based on these opinions and values, right? Not just in our individual lives and how we have relationships and plan or don't plan families, but also we see it in legislation. We have people making laws about people's bodies who clearly don't understand the basic biology and physiology of the processes they're legislating around. And that is extremely dangerous. And on an individual level, so for me as a woman, for other women, people with wombs, again, it's an issue of empowerment, but it's also an issue of safety. Because if you don't understand what's normal and what's not normal for your own body, and you also don't have the language you need to describe those events or phenomena or symptoms or whatever, then there is no way, or at least it's going to be a lot harder for you to seek the help that you need to manage and treat the functions of your body. If you, for example, had a cough and it felt like it was in your chest, you would have the language to say, I'm coughing, I'm bringing up this kind of green stuff, my lungs hurt. You would have simple, basic terminology. And yet, if you're having, let's say, unusual discharge, a lot of people don't even want to say the word discharge. So they might say, there's this stuff coming out. I don't really know what color it is. I haven't looked. And then again, there's this, is it coming from your vagina? Is it on your vulva? So we have the words and the knowledge about virtually every other system in our body. But for some reason, when it comes to the reproductive system, we're not as empowered as we could be. So it's definitely a safety issue on an individual and really on a social level.
I couldn't agree more. I've seen so many times where a woman will come in to the emergency department, to OB-GYN, to my practice and say, I'm having pains in my stomach. When what they're talking about is menstrual cramps or possibly endometrial pain. And so I agree, having that language is really empowering. I think also when we are interfacing with the medical model, there's so much implicit bias that comes from physicians, particularly toward women. And so the more articulate we are, the more in a way we're able to read the room and play the game and have our concerns heard and responded to. And that's an unfortunate fact that we have to manage the emotional and intellectual setting, but it is actually a reality in many settings that I've experienced.
Yeah, it's a shame that we as women have to assume that burden or the onus is on us to a certain extent to
Exactly.
communicate clearly, because a good practitioner, even if a patient comes in and says, I have pain down there, or
Yeah.
there's something coming out down below, a good practitioner will be able to really dig into that history and figure out exactly what's happening. So the patient shouldn't always have to be the one who can be super articulate. But as you said, unfortunately, that does empower you in that dialogue, and we can use all the power we can get.
Absolutely. It also empowers us to find accurate information and know how to look for that accurate information if
Yeah.
we're double checking a diagnosis, if we think we have something going on and our doctor's just not recognizing that. It gives us a little bit more language to search things more accurately by. You state in your book also that understanding your body is a lifelong process. It's important to understand that other people's journeys may be different from our own. And one of the things, there's so many things come to mind for me about that, of how we compare ourselves and we think there's something wrong with us starting so early on, the age we get our first period, our breast development, whether we're not developing breasts yet, whether our breasts are bigger and we're getting more attention in unwanted ways for that, the amount of flow, how long it takes us to get pregnant, the list goes on. And I'm wondering, what are some of the differences if you could wave a magic wand and have women understand and be more proud of? What are some of the things that you see coming up that you hear women talking about where they're just not recognizing that each of us is unique and that's important for whatever they're going through?
Obviously, my sort of milieu is pregnancy and birth. And I think, especially nowadays, because of social media and just the way the world works, women are constantly comparing themselves to each other when they're pregnant, when they're giving birth, and when they're postnatal as well. So women will compare, is my bump the same size as somebody else's? Is it the right shape? Are my breasts looking weird? Do my labia look strange now that I'm pregnant? Am I still sexual? Am I still attractive? Does it feel the same for my partner? Is my baby moving the same way? And then am I going into labor properly? And I'm saying that in quotes, obviously there's no proper way. Am I making too much noise in labor? Am I doing it right? Am I taking the right drugs? Am I not taking the right drugs? Am I birthing my child in the correct or the wrong way? And again, obviously there's no right or wrong. And then postnatally, it's a whole other train wreck of us comparing ourselves to each other, how quickly we can get back into shape, we can slim down, we can look quote unquote normal again. And yeah, unfortunately, should or could be one of the most transformative moments in a woman's life. It's fraught with comparison and insecurity. And I think that just goes through the whole reproductive sort of life cycle, really.
Do you think some of that's just the natural way women compare? Or do you think, because for me, I think that when we are experiencing more communal living, more villages, more lifestyles where we're exposed to pregnancy, birth, death, parenting, child raising, all the things, we have a broader sense of the normalization of a wide range of experiences, but I think we're so siloed that we might not see that.
Mhm.
What do you think drives this insecurity and comparison and anxiety? Or some of the things are certainly more than one thing, but
Yeah, I think it's a lot. I think social media is part of it because if you want at any given time of the day, you can look at this little black square in your hand and compare yourself visually to
Mhm.
countless other women around the world. Also, the way people talk about pregnancy and birth and just bodies in general nowadays is extremely polarized at times. And these things are always going to be contentious. But I think especially now, there's a lot of really polarized discussion around sex, gender, pregnancy, birth, all of these issues. It's very easy to get caught up in that tailspin. And also, yeah, as you said, maybe if we lived in a more communal society, we would be sort of living among other women's bodies all the time, and it wouldn't seem like such a big deal. Like the gym that I go to, um, just particular sort of culture of that gym is that the women walk around naked in the locker room and in the sauna and the steam room. They're all just sitting there and it's all out. And these are women of all ages, shapes, sizes. And at first you might go, oh, this is a bit weird. But after you go back a few times, it just feels absolutely normal. And then you're hardly noticing that you're having a conversation with somebody who's got her boobs out and it's just normal, right? But because I'm not suggesting we should all live that way all the time. But the point I'm making is that because we're in general so on the other end of the spectrum, that we don't see a range of different body shapes, sizes, functions, feelings, that when we do go through a really physical, visceral experience like childbirth, it becomes really a flashpoint because all of a sudden we're comparing, all of a sudden we're bombarded by images. We have no time to build up to that. Yeah, it's, as you said, there are numerous factors. And I think we're just not used to perceiving female bodies and birthing bodies in a way that is not exclusively sexual. We're just not used to perceiving each other in just a kind of with a sort of normal, healthy curiosity. It always seems really loaded, doesn't it? Really fraught with meaning.
it does. I love that experience when I'm in a sauna or a spa and we're all just letting it hang out. Because it just also, for me, even contextualizes, oh, even though I see other women's bodies all the time in my work, having my own
Hmm.
body naked this is not what happens in a hospital or a birth, right?
Yeah,
So
yeah.
we usually have birth. I was actually invited to a clothing optional birth once and opted to keep my clothes on, thinking that as a midwife is probably a much better idea.
Sure.
But I do love that kind of normalization of just being nude myself amongst a variety of shapes, ages, sizes. And I think also when it comes to ageism, it's a really beautiful way to be exposed to bodies that we don't usually see unless we are healthcare practitioners in that normal
Hmm.
arc of life, right?
Hmm.
When we talk about this sort of like homogenization and normalization that we maybe expect ourselves to fit into, one of the areas that you talk about beautifully and importantly and at length in the book is the homogenization of stages of labor, length of labor. And we were talking about birth trauma earlier. I did a survey as part of my article writing this year, had over 100 responses, and what came up really consistently as one of the biggest flashpoints for a woman experiencing birth trauma was actually those women who had their labor induced or augmented with Pitocin. And it seems like it wasn't just the Pitocin experience, although that was part of it. It was the suddenness of the contractions and that intensity. But it was also the way that the transition from the trying to have a baby without induction or Pitocin got very quickly, those women got very quickly corralled into something's wrong and we need to do something. There is a tremendous lack of evidence around when it's best to induce. We see the data shift all the time. Don't induce till 39 weeks. Let's induce at 39 weeks. Um, there's a lot of misinformation about the lengths and stages of labor and also when labor even starts. So I would love to hear your thoughts and have you share your thoughts. Obviously, sometimes induction is necessary and important, and we're not dismissing or diminishing that. But what are some of the challenges, pitfalls, or things that really in your research you feel that you shared in the book are most important that you'd want to communicate to women about understanding induction? And also lengths and stages of labor.
Yeah, great question. And I feel we could have a whole podcast just
We
about that.
could.
We could write
Or
another book
5.
probably.
We
Yeah,
could.
we really could. But yes, what struck me when I was researching the book was I've been a midwife for 10 years now, and inducing or augmenting somebody's labor is something that I have done countless times. I honestly couldn't even estimate how many times I've done it. And absolutely, I appreciate your disclaimer that we're not knocking induction, we're not knocking any interventions. These things absolutely can be life-saving and are tremendously important if used judiciously in the right situation. And so I've been doing this for years and doing it with a certain regime of dosage and timing and things that I just believed was standard across the world, because why would my hospital be doing its own thing when this is such an important and commonly performed procedure and has been since the late 1950s, early 1960s. And I did a little survey on Instagram, and most of the people who follow me are either student midwives or midwives. And I said, what's your regime for induction of labor? Can you just share with me what's going on in your unit? And it absolutely astounded me that almost every answer was different. And that everybody was administering what you guys call Pitocin, we call syntocinon, but it's the same drug. Everybody was administering it with a slightly different dosage, different timing, different kind of scale. Some of us were using routes that were not licensed. And basically, like, we were all making it up as we went along. And these aren't like little mom and pop kind of birth units. Not that there's anything wrong with those birth units, but generally these were people responding from really big urban established hospitals. Like in my hospital where I usually work, we have about 6,500 babies a year. So it's, it's a pretty sizable place.
Yeah, and it's not like you're making up birth positions and like, oh, try this position. Try where people are making up things with medications that can have very significant side effects.
Yeah, and I was like, hold on a minute. I've been doing something for years that not only did the women not fully consent to because they weren't given all the information and told this is just our made up regime, but I didn't consent to it because I didn't know that I was administering something that was this kind of idiosyncratic, kind of local protocol that isn't widely followed. And that really gave me pause. And I thought, so I tried to drill down into the numbers of how many wombs around the world are given Pitocin each year. And this was a task, let me tell you, because some countries publish data about how many labors are induced. Even fewer countries publish data about how many labors are augmented. So that means sped up after they've begun spontaneously. And there's even less information about the people that receive synthetic oxytocin after birth to assist with the third stage, the birth of the placenta and the membranes.
Which is actually standard in a lot of U.S. hospitals. Babies out, Pitocin's administered to make sure that placenta comes out.
Yeah, and it is, I would say it's the predominant choice for third stage here, but it is offered as a choice. So I couldn't get the complete data because those numbers unfortunately just don't exist. But what was evident was that probably hundreds of millions of uteruses every year are given synthetic oxytocin. Arguably, this is the drug that is most used on wombs of the world every year, one could say. And yet, we are making it up as we go along, and we don't fully understand the effects that this drug and that these various regimes have on not only duration of labor, but also mode of birth, breastfeeding, mother's satisfaction with the birth experience, perinatal mental health. There's even some interesting information about whether or not synthetic oxytocin has any correlation with postpartum depression, things like that. So we just don't know. And to me, I thought this is just actually a scandalous oversight, or it's just wild that this is happening and it's not in the news. And I know obviously I'm a bit biased because I'm a geek about this stuff and it does really interest me. But genuinely, I thought this is just remarkable that this is a medication that's being used on most of the wombs in the developed world and many in the developing. And we just don't really know what we're doing. So,
Yeah, it feels like it's not geeky to me. It feels fairly revolutionary, actually.
yeah, if we were all making up as we went along our regime for taking Tylenol, for example, like that's pretty huge, isn't it? A lot of people take or Tylenol
Yeah.
or Advil or whatever brand. So to think that this drug potentially is just as widely used in a certain context and we still don't really know what we're doing with it is pretty wild to me. So in terms of advice that I would give to women and birthing people who are going to go through labor or perhaps have given birth and have been induced or augmented, I would say, yes, absolutely read as much as you can about what the experience of induction is like, what are the pros and cons, risks, benefits, alternatives, so on and so forth, obviously taking into consideration your own clinical picture. But at the same time, you can't be expected to know everything. Don't feel responsible entirely for what happens to you because a lot of it is in the hands of institutions and institutional guidelines and protocols, and birth in the modern world so often is just a dance between those various forces.
Yeah, it's so important to emphasize that. I really appreciate you saying that because so many women go in with hopes and expectations and plans and then find themselves up against a beast of a system that is very hard to navigate for anyone and doubly hard to navigate when you're in labor and experiencing the intensity of labor, and then triply hard to navigate when you are literally sometimes being told, well, if you don't do this, do you want to harm your baby, right? So what do we do? And I think that importance of self-compassion and forgiveness, it doesn't mean don't go in with your hopes and dreams and your doula and your
Yeah.
advocacy and all of that, but that self-compassion is powerfully important.
Absolutely. And I was speaking to a woman recently who'd had a baby not so long ago, and we were going down the line of birth trauma conversation. She was sharing her story with me, and at so many points in her birth story, she said, and I just feel if I'd made a different choice at this point, or I should have spoken up more when they offered me this, and I just really let myself down because I wasn't loud enough insisting on this other thing. And at every point where something went wrong or a different way from what she'd expected, she completely blamed herself. And I think that's sad and that's a shame because, as I said, there are so many other forces at work. We should be able to trust the people who are providing care in that immediate circumstance, but also we should be able to trust the system and that the guidelines are there to protect each and every one of us and that they're applicable to each and every one of us. And so to just blame yourself or just take on that whole burden yourself on your shoulders when you're actually the vulnerable one in the situation is, yeah, it's unfortunate.
In your book, you talk about something that I have been on about for decades, which is the language that we use in medicine to describe women or to relate to women. So one of the things, for example, is at least here in the US, when a woman comes in with a medical concern, it's considered her complaint. And I feel like we go wrong right from there. This idea that women are complaining is so embedded, although language is in truth used for men. Anyone who comes in has a complaint instead of a concern. But also there's this language that is blaming women. It's no wonder we blame ourselves. Incompetent cervix, hostile uterus. When our baby isn't growing, it's failure to thrive. And even the term miscarriage kind of bothers me. I feel like it suggests somebody did something wrong rather than pregnancy loss, which I feel like conveys more of the actuality of what happened, but also more typically the emotion that may be associated with it. How do you feel that some of this language, you talk about hostile uterus and irritable uterus in the book as not just misogynist and patriarchal language, but a phenomenon that can actually lead to serious downstream consequences. And you share a story about
Hmm.
that with twin to twin transfusion. Can you talk more about language and health and safety?
Yeah, absolutely. We speak about women's bodies in a way that just absolutely would not be acceptable in men's health. For example, if you're struggling to conceive and somebody says you've got a hostile uterus, not only is that not an actual clinical condition, it's just a vague kind of nothingness. It doesn't actually mean something. But if it was your partner's issue and your partner, had erectile dysfunction, we would say, well, your partner has erectile dysfunction. We wouldn't say sad penis. We'd
Or we
say,
wouldn't say that he has hostile sperm if
we
he's
wouldn't say he had fistile sperm ever.
right.
We would think it's outrageous. How can you say that?
Exactly.
And yet we completely accept or just are resigned to the fact that medical practitioners speak about women's bodies in this way. So not only is it insulting and a double standard, but as you've said, it's actually really dangerous because it has serious consequences when we don't give things their proper names. So in the book, I dive into this label of irritable uterus. And this is something that I myself have used many times. I've heard doctors I've worked with use many times. When somebody comes into the department and they seem to be having abdominal pains, they seem to be having tightenings or contractions, but the cervix is not opening, they're clearly not in labor, they are having some kind of discomfort. And we do all the tests and investigations and we can't find anything. And we just throw our hands up and we go, oh, you just got an irritable uterus, and send the person home with some painkillers usually. And I had always thought, oh, yeah, that's a thing. That's like a real thing that can happen. You can have an irritable uterus, just because I'd heard it so many times from people I respect and trust. And when I actually looked into the origins of that term, it has its origins in very early kind of 18th century obstetrics, to describe all manner of pains, not just abdominal, but anywhere in the body, really. And often this term was applied to women whose lifestyles were less than desirable. So perhaps this woman had been to too many parties, or this woman was grieving too much for her mother, or this woman was a seamstress, she was working too hard. And these women were presenting with some kind of pain or ailment. And these early obstetricians were just saying, well, you have an irritable uterus. And that was the origins of this term, which we now use in a, quote, legitimate way in modern hospitals. But not only does it have these kind of spurious historical roots, but when we use it inappropriately, and I guess it is always inappropriate because it's not even a real thing, we risk missing the real problem. So in the book, I interviewed this woman, Rebecca Fishbein, who had been pregnant with twins. And she presented to her local emergency room many times in her pregnancy because she was having abdominal pains and she was really uncomfortable and she was convinced something was happening. And I think some sort of tokenistic tests were done. Maybe she had a urine dip and cursory examination, and she was just told, you have an irritable uterus. And she says she actually felt like she was just irritating in and of herself. She could hear the nurses laughing about her just within earshot. And she thought, my uterus is irritable and I'm irritating and nobody wants to really listen to what I have to say. But unfortunately, this pain persisted and she finally went back and she, I think, had an ultrasound, and then she had some more kind of detailed investigations, and somebody actually identified that actually her pregnancy was in serious danger. And she had this condition called twin-to-twin transfusion, where essentially one twin takes much more of the sort of circulation with important blood, oxygen, nutrients, and so on than the other twin. And both twins are at risk of death, and it can be very dangerous for the mother as well. And this was identified just at the point where it nearly became, irreversible and fatal. And fortunately, Rebecca managed to then go and get the correct treatment, and she gave birth to healthy twins, and that was fine. But she was rightfully outraged by what had happened, and she now actually has dedicated her career to researching twin-to-twin transfusion and helping other women advocate for themselves and understand the condition. But because she was labeled with this ridiculous and completely baseless term,
Right? Like a dismissive
absolutely
term.
dismissed. Yeah. Because she was dismissed in that way with this kind of false terminology, very nearly this potentially fatal condition was missed. And I'm sure in many other conditions, we are missing things and outcomes are not so good. So yeah, absolutely. It goes to demonstrate your point that language isn't just, oh, it's just nice. It just makes you feel warm and fuzzy, to use the right words. It's actually a safety issue. It's very important. Yeah.
I have interestingly, a podcast for those of you who are interested in this phenomenon of twin to transfusion with the woman who at the time was my book agent, and she had experienced a twin to twin transfusion and the odyssey that she went through navigating getting medical care for herself was quite profound. And she's a very well educated, resourced woman who had to just go to the mat to get care and be really listened to.
Mhm.
Speaking of, I want to make sure that all the pregnant mamas or future pregnant mamas listening aren't freaking out if you're having what is called by your doctor an irritable uterus, those contractions or frequent Braxton Hicks it could be, or some unknown reason. It is important to get a urine dip. As Leah mentioned, it can be a urinary infection, which I had a mama who came to me who had her air quotes irritable uterus dismissed. And in fact, she had a significant UTI. It can be another infection. Most often it's just nothing and it's fine, but this does bring us to circle back to self-advocacy. And as you mentioned in the story of the woman you shared, the nurses were laughing. And this is not an uncommon situation that women face where they go from one appointment to another or one provider to another. And the more we know statistically, at least here in the US, each subsequent time you go to a provider, the more likely you are to actually now get labeled as a difficult patient or a complainer or that kind of patient, sort of a euphemism for a mental health problem. So, how do you encourage women? Obviously, they're seeing you and they have you as an advocate, but in general, to continue to advocate for themselves when they're not being heard or listened to and have a concern or a symptom, and also navigate that system, which may then label a woman and further dismiss her.
Yeah, I definitely do want to reassure women who are going through the system, pregnant or otherwise, that most practitioners do really have your best interest at heart. And I would like to think most of the time, if you present to the ER or your midwife's office or doctor's office with an issue and you present numerous times, I would like to think that they will see that as an invitation and a challenge to get to the bottom of what's bothering you. And I think most of the time that is the case. But as we've said, some of the time that's not the case. And some of the time you do have to really advocate and push past some ignorant behavior and inappropriate treatment. And it's really hard. I know it's really hard. I actually don't have any kind of magic bullet of advice except to keep trying and know that you always have the right to see a different practitioner if the one that you are seeing isn't treating you with respect. I know it's a little bit trickier in America because there are issues of insurance and who's covered by who. And obviously here in the UK, we can just see whoever without worrying about the money side of things. So I know that layer makes things a bit harder in the States. But absolutely, just bear in mind that your health and potentially the health of your baby, if you're pregnant, is at stake. So do keep pushing. Don't be afraid to be that irritating, quote, irritating, annoying person. Because at the end of the day, you have to live in your body forever, and that practitioner might never think about you again. It's just another day in their life.
One of the
But
things I
it's hard.
often yeah, one of the things I often recommend too is being an advocate, bringing an advocate with you, because often people will be on better behavior when there are other people in the room who are witnessing, and that can really make a difference. It can also help you feel more confident and more bolstered when you do have to
Yeah.
present with something. I'd love to
Yeah.
switch gears to the menstruating womb that's not
Mhm.
pregnant at the moment. And you talk about a phenomenon that has definitely been on the rise, certainly with the availability of universal suppression contraception. And you talk about elective period suppression. And there are certainly divergent opinions on this. And I'd love to just hear and have you explain what that is to listeners, what you learned, and where you land on this, both as a practitioner and as a mom.
Yeah, so this was a fascinating issue for me personally because I'm very open in the book about the fact that my periods have always been awful. And I may be the womb lady and hypothetically know a bit more about this stuff than many other people, but it doesn't mean I'm any closer to solving what is a chronic issue for me, unfortunately. So I came across the work of Dr. Sophia Yen, who is a physician in California, and she runs a private company called Pandia Health that provides birth control through the mail, hormonal birth control. And Sophia coined this hashtag periods optional, although the concept is not invented by her, but she popularized it with this hashtag. And she is a big advocate for, if it's appropriate and safe for you, taking continuous hormonal contraception to completely suppress your periods, basically forever or until such time as you decide you want to try and have a baby. She argues that actually not only is menstruation inconvenient, messy, unpleasant, but is actually almost a disability for women, because she argues that the anemia it can sometimes cause can inhibit your physical and academic cognitive performance. She argues that it puts women at a disadvantage to men in schools and in the workplace and university, just competitively, generally in life. And she says for her own daughters, if they can suppress their periods, she absolutely would encourage them to do so as soon as they're of a safe age to do that. And she's right in the sense that when the oral contraceptive pill was first developed, this sort of pill period that women were told they had to have in between packs is actually not physiologically necessary. It was invented actually to appease the Pope, because it was thought that Catholic women and religious women around the world and kind of the church in general would not approve of something that didn't at least mimic the so-called natural cycle of femininity. Even now, to this day, many of us are laboring under the misapprehension that we need to have this monthly bleed in between pill packs. But actually, more recently, I believe the American College of Obs and Gynae, and I think the UK body as well, have announced that it's safe to take continuous hormonal contraception for most people.
I actually find that depending on the kind of contraception women are on, they feel better because they're not getting that hormone drop during that break. So they're getting fewer headaches and fewer other symptoms.
Yeah, that may well be the case. And of course, there are forms of continuous hormonal contraception, such as the coil, the intrauterine device, or the implant that goes in your arm that do give you a continuous source of hormone. But on the other side of this argument, I bring in a woman called Sarah Hill, who is a researcher in Texas. And she does lots of really interesting work on the cognitive effects of hormonal contraception. And she's very concerned that not only are these hormones potentially changing our cognitive function, possibly our emotions, our libidos in ways we don't completely understand, but also that giving these hormones to younger women whose bodies and brains are still developing could potentially be problematic and storing up issues for the future. And Sarah Hill believes that this sort of anti-period attitude is inherently misogynistic. Two very strong-minded, very educated and informed women with diametrically opposing views. And I found this really interesting, and I hope I've left it intentionally vague in the book in terms of which argument I agree with. Because actually, for me, I'm not sure exactly where I stand. As somebody with problematic periods, the idea of never having one is really appealing to me. But at the same time, I know that I don't get on with a lot of synthetic hormones. I know a lot of those are not really an option for me because they affect my life adversely in other ways. And I haven't really found a solution still at the age of 46. I'm now perimenopausal, and I'm having to dip my toe back into the world of hormones for that reason. And I still can't find a formulation that really agrees with me and that suits me. So it's a really complex issue, and I think it's a fascinating one to look at.
Absolutely. And for listeners, we do talk about some of these brain effects of contraception on teenagers and adult women, more fully matured women, in my podcast on Things to Know About the Pill. Speaking of menopause, there's been some really interesting research that has, well, and thank you. I just want to thank you also for sharing so transparently about your cycles. I have been someone who's been very fortunate to have what I would call easy menstrual cycles. I have found menopause symptoms not so challenging, but I will say I have been taken a bit aback by my emotional and cognitive experience of menopause, just getting my head around being a certain age in a certain body in a Western culture. There has been some really interesting research that's come out on the womb having many more effects on our health, whether it's our uterine microbiome and its impact on our genitourinary health, or even some research suggesting that there's a womb brain cognitive connection. And I find this really just powerful and fascinating in that we know that everything's connected, but also given the number of women who have hysterectomies, most of which we know, or at least a substantial portion of which we know, I should say, are unnecessary for things that can be treated, like fibroids, other ways. And I wonder what some of your most exciting aha moments are, or something that maybe transformed your thinking of the uterus as more than a reproductive organ as you were doing this book writing.
Yeah, I think probably one of the most mind-blowing moments for me was when I was reading around the use of menstrual tissue, or menstrual effluent, as some people call it, as a diagnostic tool. Because I grew up in America in the 80s, and periods were gross, and God forbid somebody should see you taking a pad or a tampon to the bathroom during your break in school. And it just, I very much, even though I'm a midwife and kind of a bit more enlightened about these things now, still feel it's a little bit yucky, and we're just not told that there's any value to this stuff that comes out. But what I learned,
Oh, I think I'm going to sneeze. Hold on.
yeah,
No, it passed.
okay.
Good. But what you learned,
What I learned was that there are some scientists doing absolutely fascinating work in this area. And most notably, there's a trial going on in America called the Rose Trial, led by Dr. Christine Metz, which is looking at analysis of menstrual tissue to potentially identify markers for and potentially even diagnose endometriosis. And this is huge because
huge.
on average, endometriosis can be a really debilitating and disruptive condition. And on average, the time to obtain a diagnosis of endometriosis is 7 to 10 years, with some women waiting much longer or never being adequately diagnosed.
And let's emphasize that is with going to doctor after doctor, explaining the symptoms, and then
Absolutely.
doctors still saying in surveys that even if they were able to make the diagnosis, they don't even necessarily know what to do.
This is the thing. And often it's 7 to 10 years of repeated presentations to doctors, but also years of numerous expensive, distressing, invasive, painful investigations, right? So we have like endometrial biopsies, we have laparoscopies, we have all kinds of weird and wonderful diagnostic things that we use to look for endometriosis that are not very nice to undergo if you had the choice. So to think that possibly we could just take some of our menstrual tissue, either collect it in a cup or a pad, send it off to a lab, and they would say, yeah, looks like you've got endometriosis, when that we could spare ourselves these years of waiting and having these distressing investigations, that's a huge game changer. And the technology isn't 100% there yet, and it's not, still has to be studied and evidenced, and it's not available to people now in a kind of popular way. But I really do think that probably in our lifetime, or maybe in my daughter's lifetime, these kind of diagnostic tools will be available. I really hope that they are. And that to me was like, wow. Not only the fact that menstrual blood actually has some clinical value, which seemed obvious when you think about it, but also the fact that potentially in the future, people will be spared these many years of distress and discomfort. It's just tremendous.
And when we wait those years, it's not benign either. If you
Yeah,
catch endo early, you're preventing longer term scarring, adhesions, and then all the problems that come with overuse of medication and potential fertility challenges. So this is a huge, huge game changer potentially. I love that you shared that in the book and really compared it to how much research. I think you talked in the book, you said there was something like when you look up menstrual blood or menstrual effluent, it's something like 400 articles, but when you look up semen or sperm, there were like 15,000 or something. Like this, the disparity in the research body is significant.
yeah. And that's just reflected in kind of day-to-day life. Like when I go to my local pharmacy, for example, to get my HRT prescription filled, my hormones for perimenopause, sometimes I have to go to 4 or 5 different pharmacies because there are stock issues. And sometimes there's like a serious shortage protocol, so I can't even get it for months at a time. And yet, in each and every one of these pharmacies, there's a lovely big colorful display front and center advertising Viagra, which any
Of
man can just come
course.
in and just pick up over the counter. And I find that infuriating. And I think
Absolutely.
that's just an example of how we really have to go that extra mile and push and struggle to get the funding and the research and the management that we need and that we deserve.
And it's so interesting how the disparities in the information distribution, notice I did not say dissemination on purpose. The information distribution in the US has come under significant scrutiny. I did an interview with a woman named Jackie Rotman where we talk about how in the US, sorry, I'm going to even back up and say how we talked about how on social media, you can talk about things like erectile dysfunction very openly, but until recently, it was considered censored content to talk about vaginal dryness or other symptoms that women might experience because it was somehow sexual content. And there was
Mhm.
also a big case that happened in New York City with the MTA, the Transit Authority, where
Yes.
there were
Yeah.
these ads. You know about this, these ads of
Mhm.
giant cacti for male erectile dysfunction products, but female products for pleasure were banned. But that case has been
Mhm.
won by Alexa
Great.
Fine of Dame. This is great. I would love to know if there was anything that you learned through your research for this book that significantly changed the way you practice midwifery or think about women's bodies.
Ooh, I think I probably have even more appreciation for women's bodies and people with wombs than I even had before, which was already pretty considerable. I think that, yeah, I think two areas where I expanded my consciousness a little bit. One of them was the use of reproductive violence as a form of oppression. So there's a chapter in my book about reprocide
Yes.
and the many ways that people's reproductive rights have been abused, coerced, discarded, suppressed over time in many cultures and countries around the world. I, even having grown up in America, was completely unaware of a lot of the information that I learned during my research for that chapter about the way that American people's reproductive rights have been usurped and oppressed in various
Yeah.
kind of covert and not so covert ways.
Yeah, people are
And it's,
shocked to learn that even until the 1980s, it was actually legal on the books in California to perform a hysterectomy for sterilization of women without consent. And this was rampant campaigns against Black and Latino women. You think 1980s, we're not talking about 1920s or 30s. We're talking recent.
yeah, yeah. And even now, there are cases of possible coercive sterilization of women in migrant detention centers
Yep.
and in correctional facilities in California and various other states. And this is happening now. This is
Yeah.
current. And this absolutely blew my mind because it's just not in the news. You just generally don't
Yeah.
hear about these things. So that's really opened my eyes a bit more um, to that side of things. And I guess just in terms of the way that I look at women's health in general, I'm the mother of two daughters who are 17 and nearly 21. And I can see them facing or starting to face a lot of the issues that I talk about in the book and a lot of issues that I myself have dealt with over the course of my life. And I guess writing the book in some ways has made me optimistic for them because I do think some things are changing and I think some good things will happen in their lifetimes that will benefit them. But also writing the book has made me incredibly angry on their behalfs about the injustices that they will face and the things that probably won't change. And beyond being a midwife or an author or anything else that I've done, I'm obviously most emotional and vulnerable as a mother thinking about my children. You never want your children to suffer any kind of pain or injustice or discrimination. And yeah, I think the book has made me see their lives in a slightly different lens as well.
Yeah, that anger for our daughters and that anger for other women is definitely a fire that can keep us doing our work. But it's
Hmm.
sometimes I'm just like, wait, we're still fighting this. This is still
Hmm.
happening. Yeah. Thank you for sharing that so personally. I have one question I love to ask all my guests before we part, and that is if
Hmm.
you could tell your younger self one thing, what age would she be and what would you tell her?
I think I would tell her So I think I would probably speak to the version of me who had just had her first child. This is nice closure for the top of our episode as well. So I would go back to kind of 2003 me, who would be 25, 26, who was so confused by her experience, questioning her career choices, questioning her interests, feeling isolated, feeling surprised by what her body had done and how it was treated. I think I would probably tell that version of me that it will all make sense someday and you will do something good with it. Yeah.
You are doing so much good. And I'm truly just thrilled to meet you and have this time with you. I'm excited to read
Thank you.
your Hard Pushed. And yeah, you have a lovely way of speaking both in this conversation, but also in your writing that feels personal, thoughtful, connected, and at the same time, beautifully researched and humorous at times, which is always nice when we're talking about these really intense topics too. So,
Sure.
Leah, thank you so much. We're going to have all the show notes with all the ways to contact you. But for those people who don't pop over to the show notes, what are the, say, top 2 best ways to find you and your work?
Yeah, thank you. So I'm
Course.
easily findable on social media. I'm on Instagram at Leah Hazard, just all one word, and Hazard just has one Z in it. I'm on Twitter. I refuse to call it X at Hazard_Leah. And my website is leahhazard.co.uk. That's an easy one. And you can just look me up on Amazon or your local independent bookseller, ideally, who will be able to order any of my work for you. So yeah, I'd love to hear from readers and listeners, and I would encourage you to get in touch.
Well, Leah, thank you again so much for joining me. And everyone, I hope this has been a really informative, insightful, provocative conversation where you've also felt seen and heard and recognized in your own journey of being a person with a womb. And we'll see you next time.